Okay, well, here we are, 65th annual ASH in the beautiful city of San Diego. It's good to see you, both of my colleagues here. We're going to just a quick intro to viewers and listeners because we're going to chat about a few important abstracts in CLL. So, Callie, we'll start with you as to where you practice and what you focus on.
Sure, so great to be here, and I practice at the University of California, Irvine, where I'm an associate clinical professor, and I focus on CLL there.
That's wonderful. Alexey?
And I practiced at City of Hope, where I'm a professor in the Department of Hematology and the leader of the Lymphoma Center. My practice is mostly CLL and mantle cell lymphoma. Yeah.
So I think the three of us can agree we're not going to cover the thousands of abstracts, and we're not going to hurt anyone's feelings by not covering their abstract and what they are talking about. But we're going to cover maybe a few highlights of things that piqued your interest and intrigued you a little bit. So, Callie, maybe shoot the first abstract that you'd like to share with viewers.
Sure, so I think we should just talk about the Pirtobrutinib update. I think it's particularly relevant because Pirtobrutinib actually attained its FDA label for CLL, SLL just earlier this month on December 1st. The FDA label is in patients who have at least 2 prior therapies, including a covalent BTKI and venetoclax. And so the updates we saw were presented by Dr. Jennifer Woyak, looking at extended follow-up from the phase 1/2 BRUIN trial. Patients in this study enrolled with a number of different prior therapies, but the presentation was focused on just those patients who had had at least a prior covalent BTK inhibitor. I think a unique cut of the data that we hadn't seen before was looking at patients who were BCL2 naive and then BCL2 exposed. And so what it showed is that the response rates are actually both pretty high in these groups. However, there is a little bit of a difference in the median progression-free survival, with patients who had been failed by venetoclax having a little bit shorter progression-free survival, but nonetheless, the efficacy is extremely impressive. And I think the other really nice thing about Pirtobrutinib in particular is it is such a safe drug. And so even with longer follow-up, we're seeing very good safety signals. Very few patients are discontinuing due to side effects. And so I'm very thankful that this drug is now more widely available now that it has the FDA label in CLL, and I'll be looking forward to future development of this drug, maybe even moving it to earlier lines of therapy.
You know, Alexey, the patients with CLL who fail BTK inhibitors and BCL2 inhibitors represent a challenging patient population out there. So anything you would like to add to what Callie said and any additional perspective, because these are patients I believe we're going to see more and more of in the community in the next few years.
Yeah, I agree. So they still represent an unmet medical need, these patients who fail both BCL2 and BTK inhibitors. And I do think the approval of Pirtobrutinib in this patient population is very timely, as currently there are no approved options for these patients, or even treatments that have been well studied in this population. The emerging drugs would be bispecific antibodies such as epcoritamab, where quite impressive data has been presented at IWCLL with high response rate, or BTK degraders, which are still early in development. But with Pirtobrutinib specifically, I agree, this non-covalent BTK inhibitor does seem to be associated with very favorable toxicity profile and high efficacy in this patient population. I will also point out that we are learning about novel BTK mutation in this patient population as presented by Jennifer Brown. Clearly this drug works in BTK C481S mutant disease, but novel mutations emerge, including kinase that BTK mutations such as T474 site. So clearly resistance to this drug will again be a problem after PFS of maybe 2 to 3 years, and we will need additional options in that setting as well.
Just before we move on to the next abstract, Callie, you mentioned the safety profile, and it's important. A lot of our viewers worry about the cardiovascular ones, atrial fibrillation, and things of that nature, which we have grown, and bleeding and so on. We've grown to know a little bit more with ibrutinib and the other similar drugs. These things we don't worry about with this new agent?
Well, I worry about everything every day. That's just my nature. However, what we see with Pirtobrutinib is there was almost no AFib. I think it was on the order of like 2%. And the trial didn't exclude patients with AFib. So I think even some of the AFib that was seen, which was very low, may have just been people who had baseline AFib that, if it comes back, which AFib is known to do, that gets counted. But the rate was very low. The only toxicities that were seen, grade 3 or higher in any decent proportion of patients, was neutropenia. In my own practice using Pirto, I put a good amount of patients on the trial. The neutropenia is not too bad. It almost never is a reason to stop someone. And so I think this just once again reflects the general tolerability of this agent.
Great. Alexey, give us another data, another abstract that intrigued you.
Yeah, so there was another follow-up of CAR T cells in CLL presented, the Transcend data set. At this point, it's close to 2-year follow-up of the CAR T cell data in relapsed refractory CLL. And as presented previously by Tanya Siddiqui, it is a very effective agent in a subset of patients. At this point, the complete response rate is on the order of 20%, and patients who have been exposed to BTK inhibitor, and majority of them have also been exposed to venetoclax. Of course, CAR T cells are associated with unique toxicities, including ICANS and CRS, which is still a concern in patients with CLL. And another concern is infections, which can occur for many months following CAR T cell therapy. And while it is a one-and-done treatment, the side effects from CAR T cells, including neutropenia, which persists often in up to half of patients, hypogammaglobulinemia with associated infections, viral, fungal, is a concern. So there were some infectious deaths later on study, which were not necessarily directly related to CAR T cell therapy, but they still occurred within a year of two on study. So it is important, and we might need to be quite selective about which patients will receive this therapy. But nevertheless, the complete response rate is about 20% now, and patients who enter CR do really well. But the overall progression-free survival is 11.9 months for all patient populations. So if you don't achieve a CR with CAR T cell therapy, then unfortunately it doesn't work for too long. So patients in partial response do tend to progress after a couple of years of this therapy. So I think we can do better. I think this low efficacy compared to other lymphomas like mantle cell and DLBCL may have to do with suboptimal immune environment, compromised immune environment in CLL. And I think we need to look for strategies how to enhance CAR T cell efficacy in CLL patients. Nevertheless, I do hope that we will have this agent available as standard of care in the future.
Callie, it's hard to listen to any CAR T data pretty much in anything without kind of getting back and look at our anchor point of how CAR T does in DLBCL and ALL even. It seems to be a little bit, not as good. Just like listening to the efficacy data, it's a little bit different. Is some of this because of CLL and what CLL is that we have, I guess, tame our expectations with how CAR T would do? What are your thoughts on what just Alexey shared with us?
Yeah, I would agree with your assessment. Maybe a little disappointing, but I think that reflects some challenges that are unique to CLL. And so I would say the two things that may be making CLL a bit more challenging to treat in the CAR T cell arena is, number one, there's this inherent T cell exhaustion that makes CLL patients' T cells just a little less efficacious. Next is, when you think about the average CLL patient that's enrolling on these studies, they, I believe, on Transcend had 5 median prior lines of therapy over like a decade or more. They've had their disease for so long. And so I do think, in contrast to some of the more aggressive malignancies that CAR T has been successful in, like DLBCL, ALL, CLL patients have been beat up, and they've been beat up for a long time. And so there's also, the aspect unique to the disease and the immune milieu and these cells that we're relying on to, exert this effect. But then just what has been done to the marrow itself over years and years and years of all these therapies. So I do think it is something that we could hopefully improve upon with further strategies, just as Alexey mentioned, but it's challenging, and I think it was a very challenging population. The enthusiast in me thinks it's amazing that you can do a therapy once, and some patients are still in remission 3, 4+ years later. I think the pessimist just wishes that the amount of patients that have these great responses were higher. And so is there some way that we could, find predictors for who's likely to have a response?
I was going to say that. It would be
Yeah.
very nice to figure out who you can predict, because potentially you could avoid other therapies and just move on directly to some of these things.
Yes, exactly. And if there are predictors, I think number one, you always get better responses the earlier lines you use it. Then you could also avoid, the toxicity cost in patients where it may be less likely to work.
And it's interesting. It's a very good point. And this question did come up during the session, but there is just no data so far.
Yeah,
You know,
Yes.
it's going to take some time.
Yeah.
So let's finish off with another one. Go ahead, Calvin.
Yeah, I'd say the other abstract that I'm particularly excited about, it'll be later this afternoon, is the presentation on the FLAIR trial. So this was actually a pretty large and complicated study. The presentation that we'll be hearing about is looking at the randomized portion of patients receiving either ibrutinib plus venetoclax versus FCR, which, we're not using FCR so much now in the United States, if at all. I don't actually use it, and I haven't for many years, but globally I think it still is the, standard of care for many countries that don't have access to novel agents. And so I think the things that are very exciting about the data set are that there was a drastic improvement in progression-free survival. And keep in mind, the study excluded patients with del-17p. It had to be above a certain threshold, I think 20%. But these are patients that, in theory, might be decent candidates for FCR. And a drastic improvement to PFS with I+V, but I would say also a very impressive improvement in overall survival. And we don't always see that early in follow-up with CLL studies, because of course someone's survival isn't just predicted by their first therapy, but all their subsequent therapies. I think, the things that we need to keep in mind about this version of I+V is it wasn't the kind of simple I+V of, for example, the GLOW trial, which is what led to the registrational approval of I+V in Europe, among other countries have received approval, which is just a fixed 12-month combination. This was MRD directed, and I don't know if Alexey knows a little bit more of the detail on how long patients were on drug, but I believe there are different, rules by which, the length of therapy was dictated. Yeah.
The MRD piece is actually, maybe we'd love Alexey to comment on this a little bit, because, one of the biggest things in CLL, continued therapy forever is not that attractive, and a lot of us obviously believe it's not the best thing, but we'd like to have a surrogate to stop treatment.
Right, no, absolutely. So I will say, though, that this study will not necessarily answer whether MRD based therapy adjustment is the way to go. So the rules are pretty complicated. So the MRD is checked every 3-6 months, and I'm sorry, don't quote me on that, but every 3 to 6 months. And then depending on the duration of therapy before MRD undetectability is achieved, then the subsequent length of treatment period is decided. So it is still not a randomized study in that sense. So it's not like we'll know, okay, well, like MRD-directed therapy versus continue until progression versus just stop in every case. So it won't still tell us that MRD-directed therapy is necessarily the way to go. So it's still truly a comparison of I+V, a fairly complicated schema, MRD-driven, to FCR. But so at this point, we still don't know how to use MRD outside of a clinical trial, and I don't think this trial will quite answer that. The issue is not just that we don't have any trial results which tell us what to do based on MRD positive, MRD negative disease, but also the assays that are available. It's either flow-based assays, which at this point are 10⁻⁴. They are not available everywhere, right? It's still maybe a couple of dozen laboratories which can do that, but they're fairly widely available. And then there is the clonoSEQ assay, right? So which essentially at this point can only be done in one lab, and you do need a baseline sample, so never forget to send that. So that, of course, introduces additional complexity to use of MRD in the community setting. So this trial will not quite answer this question, but it is an interesting approach for sure to these patients. You will have to have a diagram on your wall how to treat them.
Yeah, I mean, I think it reaffirms that probably there is no role for FCR. Let's face it. If you have access to the other drugs,
If you have access, I would
if you have
agree,
access to
yeah.
other drugs, there is no role. And I think to your earlier point, MRD is so important, but we are not ready to decide whether you escalate or de-escalate therapy based on MRD. But maybe in the next 66 ASH, we'll see.
76.
Yeah.
76.
I mean, I think the other data set that'll be interesting to follow is the Captivate trial. So this was the large trial. A lot of U.S. patients, though of course it was an international study, where they had a fixed duration approach, which was, once again, 12 months of the combo I plus V after an ibrutinib lead-in. And then there was an MRD guided approach. And it was a large study. I think it was like 200 some patients. I don't know the exact number. But, that data set continues to mature. We're seeing data at this ASH on what happens to patients that relapse, how do they do with retreatment. But I think it'll be nice to see side by side of these, seemingly roughly equal patients. They're all eligible for this study. They are a younger patient cohort, under 70. How are their outcomes based on whether they just all do this same exact duration, the fixed duration cohort, versus this MRD guided cohort where there were different randomizations based on what the individual's MRD was at the end of treatment. So I think it's going to be a while till we have a clear answer, but at least there's a lot of data sets that continue to get updated that provide, some clarity.
I will say, if I may add, that these doublet therapies, if we hope, and I'm going to be a pessimist here again, if we hoped that they were going to be curative, I think those hopes have been shattered by now, because we see fairly early progressions. The curve keeps very, particularly in unmutated IGHV patients, despite higher MRD rates in undetectable MRD rates in that particular patient subgroup. So it doesn't seem like these regimens will be curative. And again, we will be facing the same question whether concurrent doublet is better than sequential therapy. So we will have to answer that question as well. But at least the Captivate data showed that you can retreat these patients with BTK inhibitors at least after they progress. Once they progress following doublet therapy, and you will see responses.
Drs. Coombs, Danilov, thank you so much for joining me on the blood cancers today and the HemOnc Pulse. Thank you. Until next ASH.